about commercial and other historical characters of the clinical utilization of mini screw. And I want to start this morning with a branch of Ramus of orthodontics, which is not properly classic and traditional orthodontics, but somebody different side from the classic and traditional orthodontics. The use of mini screw, the rational use of mini screw for disimpaction of lower molar disinclusion with different kind of clinical approach with mini screw. Okay, and then we will speak about from here we will go to the pre-prosthetic uprighting of lower molars with mini screw with different methods depending on the on the beginning clinical situation. Okay. In my opinion, my experience, I found almost 5 different kind of method, clinical method, depending on the initial clinical condition of the patient, and you have to reason every time which kind of selection every time which kind of different situation we have at the beginning. For example, we cannot use a posterior vertical mini screw to upright or disinclude a lower 8 because you have to put in the mandibular branch, and the mandibular branch, even if you see a lot of articles of papers where they put mini screw on the mandibular branch with flaps, for example, I can assure you that it is very uncomfortable for the patient. It gives problems for the gingival trauma, gingival decubitus, and in the most of the cases, failure of the mini screw. Okay. So, for example, I show you one case, but you have to know from now that in the big numbers, this kind of biomechanics, it's not biomechanics. It's really a very, very simple and stupid single force of tipping on the crown of the tooth, okay, from fixed point of traction, a mini screw position is vertical in the retromolar area. The retromolar area is not the ramus, it's not the mandibular branch, okay? And you have to know before that you have this kind of selected cases more or less in 15% of the cases, not more than 15%. The other 85% you have to reason another method. I can show you other options working with the mini screw mesial to the lower molar to upright. If it's a 7th or a 6th or more and more 3rd molar. This case is obviously it's a very bad case with a lower right 2nd molar with bad position of inclusion, contact of the mesial marginal ridge of the 2nd molar is destroying the distal root of the 3.6, and the treatment option could be to extract that 2nd molar, but the oral maxillary surgeon told me, no, it's not so easy because there's the nerve, and we will have a big amount of loss of bone between the 2 teeth. It could be better to remove the 8, the lower and the upper 8, obviously, because the upper 8 is totally over-erupted, and then try to, can you do it? We see the situation after removing the 3rd molar, and only if we can see a flat and horizontal part of the mandibular retromolar area, you can think of position a vertical and distal mini screw and pull from distal side. If you have not a horizontal flat part of the retromolar area here before the starting of the ramus, you can fail for sure. Okay. So in this case, extraction of the lower third, lower right third, and at the same time, you put a brake at a button, a cleat, whatever you want. It's not a problem. Its position it's bonded to the distal surface of the second molar.
The same appointment.
Yes, same appointment could be good, but the decision is if you want to put very near, in very close time, mini screw to upright the tooth, or if you want to wait a good bone rebuild here in the alveolus of the third molar. I prefer, in a case like this, to wait. I prefer to wait the rebuilding of a good bone, but it takes not less than 12 or 14 months. You have to know it. If you wait only 3 or 4 months, there will be coagulus and osteoid and other soft tissues that are not stable for the mini screw.
So 10,
12, 14. Depends on the people, depends on the inflammation at the beginning. But in this case, I cooperated like in a lot of these kind of cases with the hospital, with the oral surgeon department of the Padua Hospital, and they asked me, no, we want to do very fast. We want to do it in the same appointment, and so it's mandatory to use the part of a bone distal to the alveolus socket, okay, the dental socket left after extraction. You can put the mini screw here. You have to use the safe bone distal to the alveolus, and it makes smaller the time.
Just a question. Considering this case, with no difficult in extraction
Yes.
of second molar, your choice should be done different to extract the second and
Yes, but
visualize the third.
It takes a lot time more because you have to think to approach the case, not to close this 3 millimeter of space or 4 millimeters of space. You have to think to close the space between the roots. It's more or less 10 or 12 or 14 millimeters. So you have to approach with biomechanics, much more complex, running loop or whatever needed for upright the root, and then have a bodily movement of the tooth.
So your choice
could be
the same.
good, but it could be good, but you have to advise the patient, inform the patient that it takes a lot of time, maybe to disinclude the seventh. If there is good bone here, it takes 7, 8 months with no problem for your brain to how to arrange the control of the vertical, the control of the tipping, and maybe you can do it without bonding the lower jaw, but it could be done, but it's very difficult if you want to move bodily. If you want only to close the space, obviously it could be with a dental assistant could do it, but it's not a dental movement, it's not safe, it's not healing for the periodontal tissue and the bone tissue where you left a big hole here after extraction of the lower molar. Okay? It's totally different approach.
Yeah. Thank you.
But it depends, in my opinion, by the difficulty of the second molar with the proximity with the nerve, and what do you want to do with the patient. If the patient can understand, you have the instrument with this kind of interradicular spaces. You can have the instruments to bring the third molar, intrude it, upright it, and mesialize. But it could take even 2 years of treatment in one part. Yes, in the mandibular bone, it could take 1 year and a half or 2 years. We will see a case very similar to this with mini screw and running loop without bending the rest of the lower arch, but it is I think not an overtreatment, not an overtooling, but an overtreatment. It could be in some cases. If patient ask you for it, you can give it because we have the way to manage it without a lot of mental or palatal anchorage or technical or orthodontic technical approach or appliances with 1 or 2 mini screw and your hands and your brain. You know it better than me. So, thermal extraction, they ask me, please, we try to put in the same appointment the mini screw, and we have to put, obviously, where is safe bone. I did not agree with this decision, but the tissues are not fat, not scarce. There are not a lot of post-extraction scar tissue. The patient was not with big cheeks. The patient was very thin. All the tissues were very clean. So we tried in this way, and you can see that mini screw was positioned absolutely 2 millimeters distal to the alveolar socket here, to the dental alveolus, and so we have good bone to pull back the crown of the second molar. But as you can see here, there are not fat tissues, there are not a lot of cheek tissues. The gingiva is very clean, and it is a thin periodontal biotype. Do you know the difference between thin periodontal biotype and wide periodontal biotype? It's very different in the decision of this case if putting the mini screw in the distal position, because the wide periodontal biotype very often have tissues, cheeks, gingiva covering the head of the mini screw, and it could be the starting point for the failure of the mini screw. Decubitus, trauma of the gingiva, pain, uncomfort, and very often the inflammation and loss of the mini screw. Okay? In this case, it was a selected case, and in a couple of months, the situation was like this. So the tooth is properly fished from the alveolus, and it's not a tooth movement. Tell me.
You could charge the mini screw in
you have to charge the mini screw in the same appointment with a very small force in every utilizer of mini screw. Please apply a very small force on it. It gives you a higher percentage of success of that mini screw. On counter, if you wait a couple of weeks without a little bit of loading, you can lose with a high percentage the mini screw. Yes, a lot of studies demonstrated it that immediate loading from delayed loading is better, absolutely better to have immediate loading. With very poor force, very low force, around 4 grams or 40 grams or 50 grams. When you have a elastic chain or a very light tie back with a metallic ligature. Tell me.
How do you choose the length of this screw?
Now, you have no problem in this region. In this region, you have to choose in your pattern of screw the longer and the larger that you have. Okay, the longer and the larger, because the visual appearance of the mandibular canal is only a radiographic superimposition, because you know that alveolar nerve comes in the mandible from the Spix spine in the lingual part. It runs in the lingual part, and in this zone moves from the lingual part to the buccal part until the mental hole, mental foramen mentoniero. Okay, so you use. I had in this period only 2 millimeter wide for 11 millimeter length, and I use that. Now at the moment, in order to have less problem for the soft tissues, for sure in a case like that, I will use a screw like that. You can see that after, with a round head, a complete round head without traumatic effect on the soft tissues. Okay, and there are a lot of soft tissues, and they can have problems around the head of the mini screw. We don't need edge, we don't need cross, we don't need slot on the head of the mini screw. Okay. So choice, you would choose the longer and the wider, and if you have the smoother of the group of the mini screw that you have in your pattern of your mini screw.
Yeah, so for how much do you have to insert on the bone to have a good stability?
It's a problem in this reason. It's one of the problem in this positioning of mini screw in the retromolar area, because you have always have a lot of soft tissues before the bone. In some image after, you can see that you insert 10 millimeters long mini screw, and only 2 millimeters keep the bone, and 8 millimeters are only in the soft tissues. It is one of the reasons, because I told you select very with your brain when and how to put it the mini screw in this reason. As I told you before, it was a thin periodontal biotype. It was a thin patient with the spaces in that zone of the arch, so you have not this problem. But if you begin to have the cheek interposing, or 1 centimeter of soft tissues before the bone, and you can feel it with anesthesia, for example, okay, they are signs to maybe to change your approach when you are approaching this kind of case. Okay, in the 15% of these cases, when you are very lucky, and you can find this kind of method, I'm speaking about disinclusion. So when we want a vertical vector, an extrusional vector of the tooth, okay, we are not speaking about a pre-prosthetic uprighting, because in that cases we have to keep our mind even in the vertical component of the vector of traction, okay, because in the pre-prosthetic uprighting we have to control the vertical. We can avoid to control the vertical. An extrusion, distalization and extrusion is wanted by us, from us in this case, because we want to fish this tooth from the position of the beginning position. So we want an extrusional position. And in every case that you put the mini screw distal in retromolar area or in the branch, but in the branch I suggested to not use it absolutely. In the mandibular branch, in the ramus.
Okay.
We always have an extrusional vector from the mini screw and the distal or occlusal or mesial part of the tooth. In these cases, it's a stupid orthodontics, because it's only pull from here, then remove the bracket from the distal part, put another bracket or a button in the occlusal surface, and continue to pull back, okay, until a very general position of the tooth, like in this way, okay. Obviously, now we are ready to start with a real good orthodontics. It is your moment to start with the real good orthodontics, because if you want to have not only save the second molar, but if you want to give something for healing of this reason of periodontum and bone, you have to bend the patient, whatever you want. You can use aligners, you can use MBT technique, MBT straight wire Mirabella, or Demon system, or tree technique, or bidimensional. The objective has to be to parallelize the roots and squeeze the bone and the papilla between the two teeth. Only if you can squeeze the bone and the papilla between the two teeth, you can reconstruct a bone peak between the two teeth, a good bone, no bleeding, no probing, and a good papilla, gingival papilla between the two teeth. Okay, you have to manage orthodontically to have a periodontal result. Okay, so the difficult part was not this, but it is very, very exciting for the dentist and for the patient. And now begin the real difficult, the real serious orthodontic treatment for this 3.7. Okay, because in this part of tissue, you cannot never have a good papilla if you have not a good contact point with a good parallelism between the roots. Is it clear? Any doubts for it? Okay, it's not absolutely a case finish. You have a very not healthy periodontum here and not healthy periodontum here. But I showed one case. It is not. You have to have always in your mind 15% of cases. There is a reason why Nicola told me 15% of cases, because in a lot of cases there are scar tissues, fat tissues, 1 centimeter of mucosa before the bone, vertical part of the ramus, and so it's not a good. It was a borderline positioning. Okay, borderline positioning. It depended on the initial condition of the patient, because it was very good patient on cleaning the mini screw. It was not cheek interposing and all the things I told you before. But the result is very exciting for the operator and the patient. Removing second molar, third molar, begin the traction. 7 months, very short time. If we decided to remove the 7 and move mesial the 8, you have to maintain a good quantity of bone during the extraction as first. It's not so easy, and it takes 1 year and 7 months at least. 1 year and 7 months at least. Moving the root, so long roots of so long 8. They are very long roots for being a lower third in a mandibular bone. Okay, but you can do it. We will see the kind of biomechanics. And here you have to rebuild a good bone peaks with orthodontics, with whatever technique you want. The important thing is begin with the end of mind, the end on your mind. The end, the objective is to move the roots, mesial, and squeeze and push the periodontal tissue between the two teeth. Okay, without with a good leveling, good parallelism, and good positioning of the contact point. I left this patient to the surgical department of Padua. I don't know how they treat after. I hope for this tooth that we didn't save the tooth and then they extract after
Wonderful.
no, it could be good in the same way because we built some bone.
Yes.
Built some bone, but it could be a disaster because we built some bone and to remove and put an implant could be a very stupid choice. Tell me, Agustino.
Before you put the meniscus, you take only the X-ray or?
Yes, only panoramic or no combine.
Not easy.
No combine. All the I know that all over the world, Combeam, surgical guide, etc., etc. But I think that they are absolutely an over
Oh yeah.
over tooling for positioning. That if you follow the very little number of guidelines that I can give you, not today, but in one morning, I can give you all the guidelines for all the positioning insertion site. You don't need for buccal, upper and lower, and palatal, upper and lower. You don't need for guides, absolutely. So you don't need for Combeam.
Thank you.
But not doing it without an X-ray, a simple X-ray, obviously. Okay. Now the counter.
And always.
Tell me.
And you are always checking after insert or not?
Nowadays, not always, but in the first 5 or 10 years, quite always. Just even to record, but when I am between the roots, still now I used to check sometimes, but in the interradicular positioning, not in the positioning where you have no teeth. Okay, in the dental zones you don't need to record and to check. I check before because the documentation in this case because I want to see how many length of the mean screw was in soft tissue, how many length of the mean screw was in the hard tissue, but it's not mandatory for the problem of the roots. Okay. So 2 things for this inclusion. It's not important the different level. High level from the mean screw and the tooth. It's desirable to have this leveling because you have to upright and extrude, crystallize and extrude. It's absolutely not wanted when you want a uprighting pre-prosthetic because you have to maintain the same plane. And second thing, try to. You can see better here, maybe. Okay. In these cases, you are not afraid about the vestibular movement of the tooth in this kind of method, because this kind of method, you have to put the mean screw in the linea obliqua esterna. Everybody of you knows what is linea obliqua esterna. It is it is 3 or 4 millimeter buccal to the end of the buccal ridge, buccal cuspids of the 5, the 6, and the 7. So the movement could be should be every time uprighting and vestibulization. Okay, if you are doing a pre-prosthetic uprighting, you have to keep in mind it. Okay, if it's head to head, it could go cross. If it is scissor bite, it could go good position, but you have to keep in mind and know where you are going. Okay, there are some tips and tricks in order to avoid or in order to improve this effect or decrease this effect of uprighting in linguo buccal direction, and I will give you after when we speak about pre-prosthetic uprighting. But Here, it's not a problem. The problem here is only to disinclude, to fish the tooth from the problematic position. Second case, it's not a classic orthodontic case. It's not an orthodontic case, absolutely. But whenever you have a partial inclusion of a lower 8, obviously a general dentist, even me, even Ivan, even Giovanni, for sure, coronato, a lot of people here in front of me cut off the coronotomy. Okay, remove the crown, and then with the lever you can remove the root without problem. But when you have the partial disinclusion with a partial part of the crown visible in the oral cavity before extraction, if you have the bone peak here, you cannot hope to have a bone peak higher than here at the end of the healing. And it seems that after 3 or 4 or 5 months of healing, there is a very good healing, a very good epithelial closing, okay, a long epithelial attachment. But the patient told you, oh, I'm very good, I'm not pain, I'm not, there is not swallow here, but you know, doctor, every time I drink something cold, I feel pain. It's obvious because if you have not hope of gripping of this periodontal covering the CEJ distal to the second molar, a little part of the dentin will remain free and not covered on the mouth. A lot of studies told us that orthodontic molar extrusion before surgical extraction can improve the periodontal status distal to the second molar. In the case of the lower jaw, they studied a lot of cases in the lower jaw. So a partial orthodontic extrusion and distalization, crown distalization, can improve the periodontal status. It seems that it means that the CJ could be a little could be covered a little bit more than in the sample without the orthodontic extrusion. But the problem was how to do it, bending all the lower arch, because if you measure the benefits and the problem, the benefits are lower than the benefits are lower than the comfort and the problem, the solving problem. So putting a full appliance to upright and move 1/3 molar before extraction, only to have an improvement of the periodontal status, was not absolutely suggestible for to do for the patient. Now with mini screw, we can have treatment time reduction, increase of result predictability, and no anchorage loss in other teeth, because we cannot not bend all the other teeth. We can do it in a very simple way, and this very simple way is this way called distal screw system. You need only one mini screw positioned mesial to the lower molar to upright. In this case, the patient was in orthodontic treatment for other reasons, okay, but you can do it absolutely without appliance in the other teeth. And you absolutely need the mini screw with crossing hole, okay. You cannot use a mini screw without crossing hole. And you do a little notch with a burr, in the enamel surface of the tooth that you see in the oral cavity, or you can put a direct molar tube and you fill it, and you stop it, fill it with the flow composite, and lock the sliding forward of the night eye, round night eye 0.18, for example, or 0.16. Quite always I use 0.18. Be careful of this zone, because we can have irritation or gingival trauma and pain and uncomfort. You cover with a plastic tube in this region, and with the same mechanics of the LOCA system, LOCA system for this sterilization of the upper molars. You can have the recovering of the initial length from the super elastic wire, piece of wire. I repeat, 0.18, round 0.18 night high, or in some cases square, no, rectangular 16 for 22 night high. Okay.
Sorry, rectangular, not only
What?
rectangular wire.
No, round. I start with round.
We start with round, and when you arrive to rectangular.
You can arrive to rectangular. It depends on the distance. Distance from the between the point of the application on the tooth and the point of application on the screw. You have to put regarding the round 0.18 a length 1.5 times the distance between the 2 points. But for example, when it moves distally, because it's not moving mesially, okay?
Yes.
When it's moved distally, if you use another 0.18, round 0.18, it's too much flexible, okay? And so to finish that movement from here to here, you have to use a rectangular, not 1.5 times, maybe 1.25 times. Tell me.
How do you stop the wire on the
Okay. The way to stop the wire, you have to see until this situation with the diastema between the teeth to upright and extrude. And it is the extrusional movement, the good movement to grip periodontal tissues and bone in the distal surface of the second molar. You lock in the min screw, inserting. You can see here the rectangular 16 for 22 at the final part.
Yeah.
You stop the exit with the flow composite, closing the anterior part of the tube of the hole, building like a tube, a closed tube here. And on the tooth, you can use or a direct tube bonded and lock it with flow composite. So you transform the molar tube in a closed molar tube, or you can make a little hole in the enamel surface of the visible part of the tooth. With the burr, you make a little hole, and you engage the end of the wire without pain for the patient, because you stay very on the surface for a couple of millimeters, and you can put flow composite even there to stabilize.
To block the wire.
Okay. You can see at the final part, in the final 5 or 6 weeks of treatment, I used the rectangular 16 for 22 night high, okay, and with one screw and one piece of straight wire, one section of straight wire without bending, without nothing to do on it. But there are initial conditions that are very very specific. You have to have a very good insertion point between 5 and 6, or 4 and 5. Between 6 and 7, it's too close to the lower molar to upright, and you will have too much force, too less flexibility of the wire. Okay, and you have to see a part of the crown in a stable condition without inflammation appearing in the oral cavity. If you have to do a flap or laser or electrobisturi to discover the crown of that tooth, it could be a problem because you add the inflammation of this part of trauma with the inflammation of the healing after your discovering of the tooth, and it cannot work well. It's the way to close with the flow composite, one of the exit of the crossing hole. Tell me,
You
Matteo.
have to tract the minuscule for closing with the flow.
No.
All the
Absolutely
flow, or you use something?
I use the same material that I use for the
the
permanent
bonding.
for the retention for the the 3 to
Okay,
3
to make the retainer.
yes, to make the retainer. It's like the composite for
Yes,
the bonding, but a little bit more.
You make some etching of the surface.
No, without etching. You put not all you feel not all the
Oh, sure.
brushing, but if you enter for 1 or 2 millimeter,
Yes.
be sure I never had the removing the spontaneous removing. You have to go with the burn if you want to remove it.
Yes.
Okay, it's very sure. The only problem in this way is that because even if you use 16 for 22,
Yes.
the hole in the mini screw is always round and not square. In some case, this screw has a square hole, but the hole made now are all round and they are very large. Every kind of wire can rotate
Yes.
into that. So the problem could be that the patient have the movement of the system in the occlusal direction. You can tell to him to come to you in that case, or to move it
Down.
down and then to come to you, and you will lock with flow composite here and lock with flow composite here. Okay. And with this very simple mechanics, it's a stupid mechanics because it's a simple movement of tipping like before. We did a simple tipping before, pulling from the crown to the screw, and we are doing a simple tipping with a single movement, single force, pushing from mesial. Okay, simply pushing from mesial. We can make distance from the crown here in distal and extrusional direction, and we can see here some more bone organizing and something more than here, and we can with a very good periodontal maintenance and hygiene maintenance for the patient, we can hope on a gripping of the periodontum, having a better sealing in the distal part of the sedum. Tell me, Giovanni.
How many millimeters for a month? Just one. You have to
Yes, then even less because you are with the third molar and you are pushing it in the mandibular ramus, so in very compact bone. But when it starts, it increases the speed very fastly. It's a very short time treatment, even this, like that seen before. They are very stupid and very simple, but they are tricks. You have to select the perfect case, and you can have a best situation in the periodontal situation, final periodontal situation here.
Do you change the wire?
In this case, I changed the wire only one time. From this one, it was around 0.18 simple night tie at the beginning, length 1.5 times the distance from the 2 point, and I change it from that to this 16 for 22 only for the last month, and it takes at all very less than 1 year. I think around 9 or 10 months, because it's advantageous movement. It's only a tipping. You have not to control with a single force and couple of force. like the movement that Filippo asked me before, when you have to move bodily in translational movement tooth. So it can be a very fast movement, even if it happens in a very hard bone, because you are pushing back a third molar in the mandible. You will see another case, we pushed a lower molar in the ramus with this method, only with the 0.18. Now, the simple surgical extraction, it was simple even at the beginning. It's not to facilitate, the objective is not to facilitate the extraction of this tooth. The objective is to give more comfortable, more bone and more periodontal tissues distal to the second molar, okay? Both in the lower jaw and in the upper jaw. You can do it, but more often you have this problem referred from the patient in the lower jaw, when you have the big hole after removing this teeth with partial infection. Okay. Okay. So, okay, it was the initial situation. If you have to bond all the lower arch, the benefit and the problems are for the problems, okay? Because it's an over treatment to treat all the lower jaw only with the hoping to improve the periodontal situation distal here. But if you propose to a patient to have only one screw and one wire, only for a segmental part of the mouth, it could be an option to give to the patient if he understands. You can give an option very brilliant for him, and you can appear like an excellent instead of other dentists that for who is the only option is to extract the tooth if there is a pericoronaritis or something like that. From here to here, something happened here. Okay, everybody of you can see. And never when you extract a lower third molar, you can have a situation like that in the distal part of the distal root of the second molar. Okay. So we have seen very stupid and simple movement, pulling force from distal side. Okay, and I gave you the guidelines, and we saw a simple case of pushing force from mesial side called distal screw system. The baseline are that you have to have a very flat and horizontal part of the mandibular retromolar area before starting the branch for the method number 1. And in this case, you have to see a part of the crown in the oral cavity before starting with this method. If you have to make free the tooth with the surgery or with the laser, this method cannot be approached. Okay? Because the addiction of two reasons for inflammation. Okay? So we saw the two methods separate between them. Now, going on, it's going to arrive every month or every couple of months, more complex cases, because the hospital, the surgical department of Padua, call Derton for this case. We cannot manage. How can we do? What can we do? They wrote. We cannot do nothing on the clinical record. Okay.
Go to Nicola.
Yeah. Well, we call Nicola. We ask his opinion, and then they want what they do. In every case, if they call me, I go there, and they want what they do, because don't see at the upper jaw. It's a disaster. This patient was a patient at the end of 6 years of orthodontic treatment,
No.
Okay. with the lower 6 teeth well aligned, a good
6
retainer. Don't look at the upper jaw because we solved even the upper jaw, but in my office, not at the hospital. In the years after, but look only at the lower jaw. It's a very big problem, very problematic situation because maybe I think it could be a result of a lip bumper left for 3, 4, 6, 5 or 6 years in the mixed dentition, lip bumper on the first lower molar, and leave it. No comprehension of the distal limit of the denture, okay, and a lot of case of infection of the lower second molar in this case. What to do? What can we reason to do? It is the final case, not good alignment, but the parents and the patient was very happy, and the dentist told to the parents to go to the hospital, to the surgical department to remove the
All 8 teeth?
yeah
No.
for remove the
6,
the
7,
the-
8?
the
7 and 8?
the lower third, to remove the lower third. Go to the dentist, go to the surgical department to remove the lower third. Well aligned, social 12, perfect social 12, perfect class 2 head to head, open bite, 10 millimeters of overjet, patient, yeah, not therapeutic, not therapeutic class 2 because it's not therapeutic class 2, it's a head to head, it's a terrible occlusion. After 7 years, the patient and the parents was really happy of this treatment, okay, no problem for the patient. They just went to the surgical department to remove the lower third, and the difficulty
And wait for eruption of cells.
Fine, the lower foot.
the problem for the doctors was to explain to the parents and to the patient, and she was 16.
How old is
Tell me.
he? How old is the patient?
16.
Okay.
So the second molars will erupt after extraction of first.
No,
He
no.
told them.
No, he told to the parents that these are the third molar, okay? The third molar are erupting,
He
so
never did
you have
that.
to go for an extraction of the third molar. The main problem was to explain to the patient that they are not the third molar, but they are very important teeth in the mouth of adult patient, because in the previous treatment they did not consider the limitation of the space in the posterior part, and maybe something in the grow went better, because you cannot fight to the dentist. You cannot say, oh, the stupid dentist made a very severe problem for all the mouth, not only for 2 teeth. So they have to explain that they have the second molar, very important teeth to have in the mouth, because the occlusion, because of the maintenance of the space, because the eruption, the right eruption of the upper. But in the upper, you saw that they did more or less the same thing. Maybe bumper even in the upper, I don't know, or other kind of distalization, distal jet, whatever cosa.
No, dico su che è abbastanza sfigato.
Sì, è sfigato, ha beccato qualcuno dei tantissimi comunque. Distalizziamo, lì bumper sotto, è un bel distalizzatore in età di edizione.
But non extraction.
You mean the problem is done by the bumper?
Yeah.
I think in the lower jaw, it's a iatrogenic result. It's not a natural result.
But
It's
we
very-
see sometimes I can see this situation
Okay,
without.
without orthodontics.
Yeah.
Okay, without orthodontics,
I saw some.
it can be okay. It's a very unlucky boy, unlucky girl. Okay, but it's a really
In
iatrogenic.
this case,
okay.
because rules of the 6 are.
Yes.
Right.
In this case, it's absolutely iatrogenic. It is the result, in my opinion, of distalization of tremendous, huge distalization without seeing radiographic, without knowing the mechanism of the growth of the patient, and that's the situation. So, social 12, class 2, perfect overjet, and one medium piece visible in the oral cavity of the lower right second molar, and a very little piece of the 3.7 in the left part. So they asked me, Nicola, in your opinion, what can we do? Maybe we go to extract 7 and 8, but if we extract 7 and 8, then who will recover the bone here for one implant? It's very difficult to, with the GTR or GBR. Nowadays, for the best surgeon, it's very difficult in the anterior part for one tooth or two teeth, and in the very posterior part for a couple of teeth. It will be covered all but the mucosa, and it's very difficult to rebuild bone. So the future for this patient should be really to have only the dentition until 16 years old. Okay. In my opinion, I told to them we can try to remove the lower 8 and stay and see, wait and monitoring the situation, and then we can decide which kind of approach we can choose. They remove the lower third, as you can see here. The lower third are removed. And I asked to the surgeon, and please in this situation ask to the surgeon, always ask to the surgeon, or the surgeon in person do it. Try to suture the flap, leaving the part of the crown of the 7th free after healing in the mouth of the patient. Okay, visible in the mouth of the patient after healing without recovering of epithelium, gingiva, or somebody on some other soft tissues. And when you decide, I go back here just for 1 minute. When you decide for a kind of method like this, in this kind of cases, you will find very poor cases like this. But if you choose for removing the lower third molar and then putting a vertical mini screw, ask to your surgeon, or do it if you are your surgeon. Do an osteoplastic here, a reduction of osteoplastic, in order to have the flap very low, okay, very low and very compressive, so you can have a horizontal and flat and low part of the bone before starting. You remodel this part of the alveolus in order to push the flap, to pull the flap very low, okay? And if your surgeon can understand, he will do, and if you cannot understand, you have to to tell him, because in that case you have much more percentage of success for the mini screw in this position. Okay, osteoplastic, so extraction of the third molar, osteoplastic, and the flap well sutured, suture to push down the flap. Okay. In this case, where we was before, after removing the lower third,
You wait how much?
we wait the soft tissues healing, the stabilization of the soft tissues,
2 months.
2 or 3 months, okay, depending on the swallowing or the baseline situation. We remade OPG, and we saw that from a little bit of inclination of the second molar, they went absolutely 90 degrees with the lower 6. I don't know why, maybe because the third molar was pushing a little bit in the roots and the teeth was a little bit inclined, and now they are worse than before. It was expected, but now we have more space for reasoning. Okay, at this moment they are lost. It is a dramatic case, so only in this kind of dramatic case, I choose to put the even mini screw for 1 week, 2 weeks, as much long time that they can stay, even in the mandibular branch. But I know that I will lose them in a couple of weeks or at least in a couple of months. This was the situation. The surgeon could do a very good job because the healing tissues didn't cover the enamel part of the teeth here, and the 3.6 is a little bit visible in the oral cavity. And you have in mind why, because we saw before the distal screw system. At this point, I told to the team, please, we remove the splint, we leave the teeth free, because there is a very complicated situation of crowding, as you can see here, of crowding between the roots, because they solved the crowding between the crowns, but there is a very full crowding between the roots. There are not good spaces for mini screw, for the interdicular positioning of mini screw. And they told me, no, we have to say to the patient, if it's possible, we have to do very fast, we have to solve this problem, or remove the 7th, the parents don't want to wait. And okay, we start in this situation. It was not right to start in this situation. It was much better maybe only to align, expand, and recover the good space, anatomical space between the roots before putting intraradicular mini screw. You can see 90 degrees, perfectly 90 degrees between the 7th and the 6th. Okay, same reason, same method of before. Right side, left side. Here there is a suture point, not because I opened the flap, but only because a little bit of mucosa went around the drill when I did the little hole on the bone. Okay. You can see here the filling with the fill up with the flow composite in the final part of the crossing hole. Direct tube in this part of the 4.7, 3.7, and one and a half length, 0.18 night eye between the two points, between the screw and the tooth. Tell me.
You put the composite before to insert the screw?
No. Absolutely after.
Okay.
Absolutely after, when you are in a good position. The good position could be with the direction of the hole it's better this position than this position. So I could have a little bit of a quarter ring more.
You close and transform it in a tube.
In a closed tube.
Okay. So you put the wire and then you fix.
No. Before you use the flow composite, okay. Then you polymerize, okay.
But how you could that the flow don't enter in the slot?
No, the flow enters in the slot.
Enters in the slot.
I don't use, because actually in that moment I had only slotted head mini screw. Nowadays I do this technique with this mini screw. I'm showing to you we are few people, so we can jump from an argument to another argument for sure. Give me 10 seconds. Give me just 10 seconds. Okay. Okay, actually, I'm using for that technique this kind of screw. It's one of the 5 screws that I use, only 5 screws. Okay, you can see this kind of head. Okay, this kind of head. It's very small. It's very smooth. I don't need to break it. There is a crossing hole, so I put the flow here. Okay, I polymerize and then I go on with the wire. So I have no problem of edges, no problem of trauma. If I have to pull or to push with the distance screw system, this is the head that I use. I use this kind of head only if I have to build a lever arm, a sectional with stainless steel or TMA inside. Okay. In this case, obviously the flow go into the slot, into the slotted head, but I don't mind about that. The only thing I wanted from this screw, it was the crossing hole, okay? And it's the reason because I suggest to do one mini screw perfect for pulling or for pushing with this system, but very smooth without edges and slots, okay? Here, composite flow composite before engaging the wire, flow composite before engaging, and only in this dramatic situation I choose to put even a couple of mini screw in the mandibular branch. Okay, it's a very not difficult, but a very poor positioning. Even if you can see on the books, on the article, I can say to you, even know, and can say to you that I'm working on it from 21 year in this year, and you can a lot of failure with the mini screw in this positioning, and that's because there is a very wide, very high soft tissue covering the bone, okay, and it's very easy to do traumatic injury, irritation of the gingiva, decubitus, and something like that in this part of the because it's only mucosa, not keratin inside gingiva, and a very high thick of soft tissue covering the bone. It could be a good direction, a very good direction for disinclusion, okay, not for pre-prosthetic uprighting. So in this case, but as you can see, I used to use different screw from right and left side, and in 10 or 15 years, I made the split mouth. So in a lot of cases, same biomechanics, same patient. The only difference was right and left, and I, month by month and year by year, understood what are the good things of the mini screw and the bad things, and try to avoid the bad things and put all together the bad things, the good things. Okay, beginning, very uncomfortable for the patient. In my opinion, the use of mini screw have to be an aid for you and for the patient. They cannot be an addiction of uncomfort for the patient, because during Saturday, Sunday, you don't want they call and leave message to the office. Doctor, I am with pain because you have enough problem without mini screw. So mini screw have to be used with rational, and without being an over problem for you and for the patient. Only for one eye. That's because not so friendly user with the palate anchorage with big appliance built from the technician and with a lot of arms and this block screw on like we saw from Filippo yesterday for 3 years, and then Filippo went and unscrew 15 millimeter screw on the palate. So this kind of solution is in Italian we say ultima spiaggia, the last
Chance?
the last chance, okay? Last chance to hide a situation from the beginning. Then I knew that one of these two screws or both of them, I will lose them in some weeks or a couple of months. But they was very useful because from beginning of treatment, having a pulling force from mesial side in the buccal part of the tooth and a pulling force from lingual part. Okay, we controlled the rotation of the tooth during the uprighting, and the same thing we could do in this side. Okay, pulling from distal side in lingual and pulling from mesial side in buccal, and only after 10 weeks, and it's normal because we told that they are stupid and very simple movement. They are only tips. Okay, we pull from the crown and push on the crown, and the apex is where he has to do. He has to be.
What about upper jaw?
We can speak about it, but after. Maybe I have the records here, but it was very much more difficult to treat. I extracted the upper seventh, upper seventh, and distalized the upper 6 and used the 8 for
in place of
okay. And so 10 weeks ago, so couple of months after pushing from mesial side and pulling from distal, and now
again orthodontics.
Now begin the real or the difficult or the real good job of the orthodontist, because if we see the teeth, all could be good now, but we want to arrive here. It's very similar, but if we see the radiographs from here, we arrive here. It's a good goal. From here, we went here. Look at this screw. We saw the screw 11 millimeter. It was only for 3 millimeter in the bone, and the rest all in the soft tissue. From this image, you can understand why it's a very big problem position mini screw in the mandibular ramus, and the same is here. And the second reason is because the direction of insertion and the direction of the force is absolutely a pulling out direction of the force for the screw. You can understand for sure. Look at this one. It's horizontal, absolutely horizontal, and the force is 90 degrees to the screw. It's absolutely very probably to have failure. Okay. Here, and we have a kind of bone or fibromucosa or some soft tissues, and now start your work like orthodontist. It was very simple until here. If the screw, if you understand where to put the screw, a piece of wire, where to put the screw, and a piece of elastic chain. Here, you can do lingual, you can do Invisalign, you can do tweed, you can do bidimensional. It's not different. School, it's not different technique. It's only the same objective. The objective is to make the major parallelization that you can between the roots, squeeze the distal root of the second molar to the first molar. Okay, you remember about the running loop of yesterday, that with running loop you can move the roots forward and then you close the space. Here the space is almost closed and you have to move forward the roots in order to improve the healthy situation of the periodontal between the 6th and the 7th. Until here, and then if you move the teeth in the right position with the right proportion with the contact point, you can see the rebuild of the cortical bone here, a good peak, and over a good peak will be always a good papilla, gingival papilla. Okay, you agree all with this periodontal link from between orthodontic and periodontal health. Okay?
Nicola,
Yes, tell me.
just I'm asking about the root canals in two teeth.
Yes, yes.
The
Now,
reason.
this is a trauma of the patient during treatment.
Yes.
Okay, she has a bicycle accident, and it was because I told to the team to wait to leave the root, giving the right space. I had only 2 millimeter at that time, only 2 millimeter wide screw, and it was impossible to not do. They exist two kind of damage of the roots caused by the mini screw. The simple damage is the little notch on the root without endodontic involvement. They are 90% of the trauma. Or in some case, if you are need to drill because you are in a mandible, and 50% of the cases of the mandible needs for a little hole before screw insertion. If you touch and if you heat a little bit the root too much, it can respond with the loss of vitality, and you have to tell to the patient and to make the root canal therapy. But it's very it doesn't happen now. It doesn't happen now if you feel the right guideline. It's not a big problem. This tooth is even in her mouth with the root canal treatment, but it was because when they are too narrow, because too close between them, you have to make a little bit of space, reposition and break it, or in this case, simply with a super elastic wire, leaving them to come out from the crowding, okay, from the roots.
May I ask, this
Ask me
this
whatever
position,
you want.
This position, isn't
Yes.
it, I mean, in wide space to move like this, it's very difficult, no? So,
From here, we
Yeah.
have not problem here now, okay? We have
so
not,
it's more distal vector also working,
yes,
not only uprighting.
and in fact, the situation at the end is a lot of distalization,
Mhm.
okay? A lot of distalization and uprighting and loss of vertical control.
So it's not a problem to go from here, no.
If you work with a couple of forces, pulling from distal and pushing from mesial, but if you use only the distal screw system from here, only with this screw system you can arrive at this point.
Mhm.
The problem from here is to do a good orthodontics, okay, and move the roots
Mhm.
forward.
Mhm.
You have not to be afraid to move the teeth in horizontal, because if you apply the force on the crown, you are very far from the center of resistance, so you can expect a rotational movement of the tooth.
Mhm.
What that you don't want when you mesialize, for example, the lower molars in an extractional space of the fifth,
Mhm.
when you for orthodontic strategy, you remove the upper 4 and the lower 5, or the 4 second premolar. You have not to be afraid. The only objective is to pull out from the bone the two crowns. And in this case, having two mini screw in the distal part, in the mandibular branch, that I hate to position in that insertion point, I had to lock a little bit. You can see that the elastic chain pull a little bit down the distal marginal ridge of the second molar, and maybe it increased the rotational movement. Okay, but it cannot work more than here. From here, you have to begin. Look at the tube here.
Yeah,
you have to
of course.
position here, and then you have to work with low forces arch or what you want. I prefer with my technique position with zero information, and then go bending and bending and bending with a little bit of degrees from with these rules. Okay, from plus 30 to plus 20, plus 15 to 0, and then with running loop it's very, very useful. But in bidimensional it could be done with uprighting springs. You have to have the objective in your mind. Begin always with the end on your mind. And the good objective here is to push and to squeeze the periodontal tissues during the orthodontic treatment, because from here here there is a very big difference in the periodontal health of the mouth, not in the positioning of the teeth. Okay, it is when I started to move the roots, and it is when I finished to move the roots, only to move the roots, with second order bends or with power arm, and you are learning a lot of different technique to do it, and you can combine them together. Is the good sense of this kind of way that you are driving through in this moment. Tell me, Matteo.
So using only the mini screw, the mesial mini screw between the premolar is not enough to have an uprighting.
I was scared about two reasons. The two reasons was the rotation of the second molar, the hyper rotation, okay, and the second reason was that with these two help more, I could have only a tipping movement and not a translatory movement like Enisa told me before. How do we have only a tipping movement if I push and I pull? But I pull with the elastic chain pushing from the high to the low, the second molar. Okay, I was afraid about the rotational movement, having only the force in the buccal surface. But obviously, if I have only one of the two options, I should work only with the pushing method from the mesial side, not with the two screws. In fact, you can see here, after 10 weeks from the beginning, the right distal screw is lost.
Yes.
Okay, I had this one, and this was with pain and comfort of the patient, and I have to speak a lot of time with she, look at the result. Yes, but I have got pain. It's not comfortable for me. It's a very difficult situation to manage. I have to screw in a little bit every time to tie to load a new chain. So it can give a lot of problem in the management of the patient.
As you said, it's important to the direction of the hole of the mini screw.
The direction of
the hole.
Yes, it's in the distal screw system. the better way that you can, all right, in the all the mini screw, okay, all the mini screw are a couple of authors proposed in past with clockwise rotation and counterclockwise rotation mini screw, but nowadays they are always all the mini screw are clockwise rotational insertion, okay, like a screwdriver. So in the right side, it is the good positioning, because if the wire push on the screw, it's in the sense of rotation. So in sense of 1/2 more insertion of the screw. In this side, I had to do better if I put it in this direction, and it went from this direction. So the direction of pushing is in the sense of the clockwise. Okay. In this position, it could be 1/2. Okay. If it was not stable, the pushing force could unscrew, give an input for unscrewing the mini screw.
And
So
it's different the vector that they release, the direction of the hole. Differentiate also the vector that we have on the tip or not?
no.
Not so much.
It's only a simple single force.
Okay.
Here you have the same force.
Okay.
Here you have, it's only to make safer situation for the stability of the mini screw. Okay? Tell me.
You told before that we have to use the light force, no?
Yeah. Yes. Good. Sorry, I lock you because I understand your question. In the first 2 weeks, I put only not 1.5 long piece of wire, but only a wire that can be engaged with very light force.
Okay.
You are very upgrade, so I have to explain these little tricks to you. The normal people listening to me doesn't remember. I told
No, I
load a
also
little
was
bit.
thinking.
Yes.
Why
Perfect.
you
Perfect
load?
question. When you use this screw system, engage as for the first 2 weeks, 0.16, something that could stay engaged but without high force. Only you go to 1.5 length after 2 weeks. In every case, you load immediately the mini screw, and you have to load it immediately. Try to have a 40-50 degrees force, because it's like
How many? 40?
40 or 5
Yeah.
or 50, 40 or 50. It's I'm not a lover of the dynamometer. I'm not with me when I work. So for an elastic chain could be the minimal extension to leave it in place.
One hole or?
Yes, just one hole. Okay, one hole more, just to make in order it stays in position for the 2 weeks. Okay, without coming out. Okay, for a metallic ligature.
From 50, and which is the maximum force?
No. When it is stable, you can load until 250 or 300, like orthopedic forces. It happens when I use, but I suggest you to use when your skill is more improved, more developed, between with elastic, intermaxillary elastic between teeth and mini screw. Okay, I wait the good stability, and I go with the very high force elastics even in the head of mini screw. But in that case, there is not a continuous force; it's an interrupted force, and mini screw doesn't like the interrupted force because here it's success in the long term. Okay.
So better not to
If you
use.
like this kind of argument of we can stop and go to upper molar distalization, I find it's good for a Saturday morning for wake up and make it a little bit different. We can see something different from the classic orthodontic, but I thought that the real important orthodontics starts here to move the roots forward. Tell me, Giovanni.
You want you prefer to use light forces because not to have ionization because
At the beginning?
At the beginning.
No, at the beginning because there is absolutely.
Hi, Kirsten for Lucy.
Good morning.
May I take some bags for ready? Or
Abbiamo tutta la mole borse con
We have to bring some other materials inside there or not? Do you want we make a very short break now?
Yeah.
Okay. So we make tell me. Hey guys, only 1 minute.
Very light forces during the first 2 weeks.
Yes.
Then we can start
To go,
increasing
no.
or immediately.
Immediately.
Why use light forces?
Yes, because there is no biological, no one biological aspect of the stabilization of the mini screw. It is only mechanical reason. Okay. So when it's like when you put quando metti un chiodo nel muro, ok? Se tu ci dai un po' di forza, si incaglia, si incastra un po' e quindi è proprio un motivo meccanico di far incagliare un pochettino.
Perché se invece usi una forza pesante, cos'è?